Good evening. First of all, I would like to thank the course directors for the kind invitation. So in the next few minutes, we are going to say a few things about the transeptal puncture, which is actually a technique introduced back in 1960s as a method to enter the left atrium from the right atrium in order to measure pressures and evaluate the valvular heart diseases. However, nowadays it's becoming we are conducting this procedure more and more often because of the new, mainly structural procedures. And as you can see here, nowadays we need the transeptal puncture in order to access left atrium for a mitral valve, for M-TEER, for a valve, for valve in ring, for PVL closures, for LAA occlusions, and electrophysiologists also for ablations. The goals of the transeptal, of a good transeptal, ideal transeptal puncture are three. Mainly is to achieve LA access in a safe manner using usually large bore catheters at a high-end position that enables the necessary manipulation and position for the intended procedure. Secondly is to avoid any trauma to the adjacent structures. And finally, to provide the safe exit from the left atrium. And the most basic thing is to understand the anatomy in order to conduct a safe procedure. Here you can see the fossa ovalis, which is part of the true septum and is located in the lower posterior part of the septum. You can see that anterior superiorly it's adjacent to the aortic valve, anteriorly is adjacent to the tricuspid annulus, and anterior inferiorly to the coronary sinus. And you can see here how it looks from the right atrium and from the left atrium, the septum. We need the echocardiography, the transesophageal echocardiography. Here you can see 3D pictures how it looks, the SVC, superior vena cava, inferior vena cava, fossa ovalis, aorta, and coronary sinus. And actually we need three main landmarks, three main planes, as Dr. Vrettos mentioned before. The bicaval view, which keeps the orientation from the SVC to IVC. The short axis view orientating from the aorta, which is anterior to posterior, and finally the four chamber view for some of these procedures in order to assess the high in the left atrium. And here you can see how it looks in the TOE. On the upper left side is the bicaval view. You can see the tenting of the catheter. Upper right side, the short axis view, and bottom left side, you can see the four chamber view and the measurements we do in the left atrium. What we need is speaking the same language in the cath lab between the interventional cardiologist and the echocardiographers. In these three planes, superior inferior related for cava, anterior posterior related for aorta, and high low related for mitral annulus. We need some equipment. The transeptal kit involves the broken bone needle and the sheath, and 0.32 or even 35 wire, the TOE guidance, and the fluoro guidance, mainly the AP view. Here you can see the sheaths and the needles we use. The higher the number, the more acute the bend it is, and it goes up to 8.5 or even 10 French for the sheaths. How we use the needle in the sheath. This is a nice technique, the overhand technique, in order to avoid the needle coming out from the sheath. So we put 2 or 3 fingers in between the flash port and the needle hub to avoid any damage. These two should be moved as one system, and the needle hub should be aligned with the side arm of the sheath. And entering both of them, the arrow should point at 4 to 5 o'clock. And keep in mind that turning clockwise, it goes posterior, and counterclockwise, anterior. So starting the procedure, once we gain the femoral vein access, the transeptal sheath and dilator are advanced over the guide wire to the SVC under the AP projection and the bicaval view. Then we retract the wire, and the needle is advanced under guidance, avoiding pushing the needle over the tip of the sheath. And we start the pullback, which hopefully we see the 2 jumps. The first jump is from SVC to RA, and the second jump from RA to the fossa. Sometimes most of the operators prefer to give some heparin, 1,000 or 2,000 units of heparin prior to the septum, to the puncture, in order to avoid any thrombus formation. And this is our TOE guidance. We start with the bicaval view, and once the sheath falls into the fossa, we are looking for the tending in this superior-inferior axis. And once we are happy with this plane, we go to the short axis view in order to guide ourselves in the anterior-posterior position according to the aorta. And if it's a case of M-TEER, then we should switch to the four-chamber view to measure the high from the puncture site, from the tending, and the mitral annulus as described before. And when we are happy with that, we are ready to cross the septum, to advance the needle. We should be, before advancing the sheath, we should be sure about the proper position. We can see the bubbles coming out since we're in continuous flush. We can measure the pressure. We can inject contrast. And once we are okay with that, we advance the dilator and the sheath. We retract the needle and dilator and leave the sheath in LA, and we never forget to fully heparinize our patient. Many challenges can somebody face, very large atriums or a small atrium, aneurysm, hyperelastic atrium, thickened and fibrotic atrium, septum, or even a prior septal occluder. All these are challenges. Hopefully we have some tools, especially for floppy or hard septums, like the radiofrequency ablation. You can see here on the left side how applying radiofrequency, the wire jumps into the left atrium and makes our life quite easy. The most important thing is, as mentioned before, the site we target for the transeptal puncture. It depends actually on the procedure we aim. And mainly for M-TEER, we aim to be quite posterior, which is the most important in order to gain high in the left atrium, and superior mainly mid-high, but posterior mostly. And the safe puncture should be at least 4 centimeters from the mitral annulus in order to have space in the left atrium for our maneuvers, and we can be less strict for lateral targets or for functional MR. For LA occlusion, the optimal site is inferior and posterior, which offers good access and good alignment with LAA neck in most of the cases. Complications, many complications can happen, as you can imagine: hemopericardium, perforation of the aorta, thromboembolism, air embolism, or iatrogenic ASD, which we consider closer when there is a significant tearing of the septum, or when there is bidirectional or right to left sanding with hypoxemia, or significant concern for paradoxical embolization. So to conclude, the ideal transeptal puncture should be safe, should be made under both angiographic and transesophageal guidance, should be made according to the attempting procedure, and should be safe again. Thank you.
Thank you very much for excellent presentation. I think we are going to move on because we are out of time. Thank you very much once again.